So I have a somewhat crazy question. So Anil Sood and others published on paraneoplastic thrombocytosis in ovarian cancer. Considering, this is a question to the last speaker, so considering the effect of niraparib causing thrombocytopenia, did anybody think about, was ever considered that maybe in those cases where there is very high thrombocytosis in ovarian cancer patients, the niraparib-induced depletion or reduction of platelet number might be somewhat beneficial, or that's too crazy of an assumption?
Kathleen, do you want to answer that question? I can have another comment at the end also.
Yeah, I don't know that we internally have looked at that data yet, we've certainly looked at the platelet drop by kind of where you started and percentage drops, and that's sort of working its way into an algorithm maybe for alternative dosing in the future, but we're not quite there yet. But I don't really think we've looked at the concept of thrombocytosis. I mean, you absolutely quote correctly that thrombocytosis is a negative prognostic factor in ovarian cancer, and there's a lot of rationale behind that. But I don't think we've looked at it specifically with the niraparib yet, unless you know something, Antonio.
So we did that exploratory analysis in this NOVA trial, and what we saw is that at the time of progression, the rate of platelets rise up in the control arm before than in the niraparib arm, curiously. That was the observation that we had at the time of progression, because thrombocytosis is an adverse prognostic factor. That is the only thing that we can say.
Yes, if it could be not surprising, because the inner mechanism collegating inflammatory aspects to tumor progression are already new, so it is not a crazy question.
Yes, therapeutic effect of thrombocytopenia.
Can I just comment on that? So you do also have anemia and neutropenia along with thrombocytopenia, is that right?
Yes.
Yeah. So it appears more likely myelosuppression kind of effect rather than...
No, but that is an aspect related to the toxicity of the drug. The speculative question is that one particular aspect, which is interrelated to inflammatory aspects that can have a link to tumor progression, at the end of the day could be a positive effect. Can I ask Kathleen a question, Antonio?
Sure.
It was very nice to see the difference between dose and response, which is different in BRCA and non-BRCA mutated patients. There is a suggestion of more activity if the dose is higher in non-BRCA mutated patients. I guess if you have any data about a different toxicity profile of the drug in the two cohorts of patients, is more toxic in BRCA patients or not?
I don't think we saw that. There's not there may have been some trends, but nothing statistically significant. Although you might expect that.
Yeah, we may expect it, in fact.
Okay, so Dr. Scotté has also a question.
Yes, Kathleen, a new question on toxicity. Is there a place for supportive treatments as well as G-CSF, as well as platelet growth factors, L-thrombopag or milplastin, for example? Because in the guidance with chemotherapy, when the level of febrile neutropenia is up than 20%, we have to deliver in prevention, prophylaxis, a G-CSF. I see that neutropenia is around 20, so is there a place for G-CSF or not? Because it's a maintenance treatment and it's an oral treatment. Is there a place for L-thrombopag or milplastin or other treatments? Are there studies? Are there any opportunities?
So it's complicated to give G-CSF with an oral agent that's dosing daily. So trying to do something to prevent the next cycle from being delayed, for example, which we do quite frequently in intravenous chemotherapy, would be difficult to do here because you have patients taking the drug the whole time, and then the question of the interaction of having someone on growth factor support and what is a type of cytotoxic therapy. I mean, PARP inhibitors, you can argue about this, but they are probably more cytotoxic than they are molecularly targeted. They're kind of both. So as a preventative strategy, I think there's always possibilities, but I think it would be pretty complicated. We do, sometimes we'll use growth factors, Neupogen more than Neulasta. I'm sorry, I'm using trade names. So if you have someone that's kind of close and you want to just bump them up before you restart their therapy, like if they're on hold, we'll sometimes do that, like 3 days of dosing, bump them up really well, and then they're on drug for a bit and they would drift back down. So there's a sort of back and forth of using things. It's hard to put that into an algorithm though, because people, respond differently. So I think there's a role for potentially doing things like that in folks that have low level drops in white count. But the dose modification really addresses it well. And I think the fact that we're not seeing efficacy detriment with the dose modification for both platelets and ANC reassures us that we don't necessarily need to do that. We don't need to keep people at 300 necessarily. So I think at this point I would say probably not, but I'd be interested to know what my colleagues think.
I agree with
I think with a dose modification that we really extensively analyzed within the study, we have the perfect tool to tailor the dose on an individual patient basis, and so I think this should be the way to go.
Can I agree?
Yes. Last question. Last question.
So, Dr. Lorusso, in her presentation, talked about the need for maintenance therapy as patients do have various symptoms, including fatigue and pain and several others. And then in Nuraprib's study, NOVA study, you did mention about anemia, but you don't see impact on quality of life with increase in fatigue, or what I'm referring to is there any different mechanism for fatigue other than anemia in these patients? And that's not picked up in the instrument that you use as any worsening of the effect on quality of life.
Yes, I would say this is my impression. My idea is that the instruments we have in this moment to evaluate quality of life in our patients are not so sensitive to capture really how the patient is. Because really I can't imagine that 70% of patients experience grade 1-2 anemia, 70% of patients report fatigue, grade 1-2 fatigue, and this has no impact on quality of life. Really, I think that it is a problem of the tools we have to measure it.
Yeah.